and thank you for inviting me to share some of my knowledge about this condition that, as you heard, it is quite rare, but it is quite important to know. And let's keep it brief and call it HLH. It's much easier to talk about, say it as HLH. And then before I begin, just a few disclosures. I have done some consulting work with these companies, Novimmune and Sobi, and there might be some off-label use description of these medications as well. So what is HLH? Because you are a neonatologist, you probably have heard the other HLH, hypoplastic left heart. That is not what we're talking about. So it's a big word, Hemophagocytic Lymphohistiocytosis. This has nothing to do with another histiocytic disorder you may have also heard about, LCH. These are completely unrelated disorders. But let's break down the word. So the word hemophagocytic comes from heme, which means blood, and phagocyte is a cell that eats other cells. So that's the word hemophagocytic. Lymphocytosis means expansion of lymphocytes, and histiocytosis means expansion of tissue macrophages. Those are the histiocytes. So that's where the disease gets its name. And so this is what hemophagocytosis looks like under the microscope in a bone marrow biopsy. Shown here is a large macrophage, which I'm outlining with the laser pointer, and inside the cytoplasm of this macrophage are other cells that the macrophage has ingested or eaten. So this is the hallmark that gave the disease its name. But let's dig deeper. That still doesn't tell us what this is. The most important thing to remember is that HLH is not a single disease entity. It is not a diagnosis in itself, but rather it is a clinical description or manifestation of many underlying diagnostic entities. And what all of these diagnoses share in common is extensive systemic inflammation that involves lymphocytes and macrophages. There is a condition known as primary HLH, and that is caused by congenital or genetic deficits in the cytotoxic immune response. And I will get into a little more of the details of what this means. How does extensive inflammation manifest itself in all of these conditions? It starts off, we know that in all of these conditions that give rise to the manifestation of HLH, there is activation of macrophages. These activated macrophages eat blood cells. That leads to cytopenias. So thrombocytopenia, anemia, neutropenia, usually all blood lines are affected. The macrophages invade the liver, causing inflammation of the liver or hepatitis. And for whatever reason, there is a consumption of fibrinogen. So you end up with a consumptive hypofibrinogenemia. So these are the clinical manifestations which are caused by, all can be related to activated macrophages. Why are the macrophages active? Because there are inflammatory cytokines that are activating the macrophages. Where do these inflammatory cytokines come from? They come from activated lymphocytes. So this is the main problem. You have extensive activation of lymphocytes. These lymphocytes release cytokines. Those cytokines do two things. They activate lymphocytes again, so there is this vicious loop. And then they also activate macrophages, and then these activated macrophages cause these symptoms. This is not a new disease. It has been known for a while. It was first described in the journal Lancet. And this patient that was described in this paper, the paper was published in 1939, but the patient was described was originally seen in 1929, so it's almost 100 years ago now. The first description was found in the literature. And this patient was described as having fever, wasting, splenic and hepatic enlargement, jaundice, purpura, anemia, leukopenia, and then phagocytosis. So these are the same clinical manifestations that we now recognize in this disease. And it was a few years later, it was found that this could be familial when two infants in the same family were described who had similar features. This was, in the 1950s when these drugs that we have nowadays did not exist. And so this has been known for a while, but then finally the Histiocyte Society came together and in the 80s and 90s came up with this terminology of HLH. The Histiocyte Society also came together to come up with diagnostic criteria, and they conducted a clinical trial that was called HLH 94 because it was 1994 when the trial started. It was in 1999 that the first genetic defect mutations in this gene called perforin were identified. And then in the year 2004, the diagnostic criteria were revised, and the next clinical trial initiated called HLH 2004. And the diagnostic criteria from HLH 2004 is what most physicians use to diagnose HLH today. So what are those criteria? And those are listed here. There are 8 features, and for the HLH 2004 clinical trial, if a patient met 5 out of these 8 features, they met the diagnosis of HLH. And this was fever, splenomegaly, cytopenias affecting 2 cell lines, elevated triglycerides or reduced fibrinogen, presence of hemophagocytosis in the bone marrow, spleen, or lymph nodes, a decreased NK cell activity, elevated ferritin, or elevated soluble CD25, which is also known as the IL-2 receptor alpha. If 5 out of these 8 features were present, in the absence of a malignancy, the patient was said to have HLH. Now, so this is the dogma that is still practiced, that if the patient meets 5 out of 8 diagnostic criteria, they meet the definition of HLH. If a genetic mutation is identified, we now know of several genes that lead to HLH. It is called a primary or familial HLH. If there is no mutation, it is considered to be secondary HLH. And if the HLH recurs after treatment, it is again labeled as primary. That means there's something intrinsically wrong with the patient's immune system. The problem is that those criteria were established in 2004. That was 17 years ago. We now know a lot more about the disease, and we know a lot more about the manifestations of other diseases that can be confused with HLH. And I will illustrate that with some examples. And so this is the one that is most relevant to this audience. And this is a true case, and I have several like this. So we got a call from a newborn IC from our NICU saying that there was a full-term baby male who was born and found to be in respiratory distress, and there was very difficult to revive, and eventually ended up having to be intubated. And they found that there was a massive liver and spleen enlargement, also noted to have petechiae, and that led to the CBC, which showed the baby had pancytopenia. And so they suspected sepsis. All cultures were drawn and antibiotics were given, but it made no difference, and the cultures were negative. But because of the hepatosplenomegaly and petechiae, a bone marrow biopsy was done, which actually showed hemophagocytosis. So when they put that, they started thinking, could this be HLH? Because we at Cincinnati Children's, everybody thinks of HLH. And so they checked ferritin, it was elevated. They checked soluble IL-2 receptor, it was very high. The fibrinogen was not low, but it was not elevated either, it was just normal. So we have a baby now who has splenomegaly, which is one of the features, has cytopenias, pancytopenia, elevated ferritin, elevated soluble IL-2 receptor, and they saw hemophagocytosis in the bone marrow. And so met the diagnostic criteria, and that's what they called us. Now, remember, no infections were found, and the HLH markers are elevated, so they initiated treatment with dexamethasone. But fortunately, and one of the very attentive nurses in the NICU noticed that there was a small lump in the baby's axilla. So it turns out this was an axillary lymph node, That is highly unusual. It is never found in HLH. So they got a lymph node biopsy, and it turns out this baby actually had a lymphoma. It's extremely rare, but newborn baby with a lymphoma, yes, it can happen. And we subsequently have identified several such children. Two of them were newborns. This child had a lymphoma, another baby had a leukemia, that were all initially labeled as HLH, and they were all treated. But some of them were older children as well, and they were all diagnosed and treated as having HLH due to the HLH 2004 criteria. But they all had either underlying malignancies or infections. So we published one paper, this was in Pediatric Blood and Cancer now 3-4 years ago. And in this paper, we described 9 such patients. And unfortunately, only one is surviving. All the other 8 patients died because they did not get the right treatment up front. So let's go back and visit this pathogenesis of HLH. And if you can imagine, lymphoma is a collection of activated young lymphocytes that could lead to the same consequences of activation and then the clinical features that are described. So what is primary HLH? Why do we care so much about this? Why is this concern? And in order to understand that, let's briefly review the normal immune system response. So if we go from left to right in this diagram, if there is an invasion or abnormal activity in our body, such as a viral infection, the antigen or the first cells that encounter it, neutrophils or macrophages or any other type of cell, they present this antigen to cytotoxic lymphocytes, shown here as CD8 T cells as an example. In response to this activation, the T cells will expand, they will become activated, and they do 2 things. One is they secrete cytokines such as interferon gamma, and the second is that by direct contact with the antigen-presenting cell, they kill the cell, and with that, the virally infected cell is killed, so the virus is eliminated. So you have clearance of the virus, and once these antigen-presenting cells are removed, they are no longer stimulating the T cells, so the immune response is also terminated. These T cells they shrink and they are saved for future use if the same virus is seen again. Now, what if this process goes wrong? And specifically, I'm talking about what if the lymphocytes cannot kill the infected cell? There are 2 problems. One, that these cells and the infections, they persist. And as long as they persist, they will continue to stimulate these T cells. These T cells they cannot kill, but they can secrete lots and lots of cytokines such as interferon gamma. And as they continue to be stimulated, they expand and they infiltrate other organs. And then these cytokines will then activate the macrophages. Those macrophages themselves will secrete additional cytokines, and now you're stuck in this vicious loop of activated lymphocytes, lots of inflammatory cytokines, and activated macrophages. This is what happens in primary HLH. So shown here is a detailed view of how the cytotoxic lymphocytes kill the target cell. They do so by creating an immunologic synapse, which is similar to the neurologic synapse, where 2 cells make contact, but there's a small gap in between. And the cytotoxic cell will then release the contents of these cytotoxic granules. In these granules are 2 chemicals. One is perforin, which is a protein that makes a pore or perforates the target cell, the target plasma membrane, through which will enter granzyme, and that will destroy this cell. So if the cell on the left, which is shown in green, the killer cell, cannot release perforin granules, or if they don't have perforin, then the cell on the right, which needs to be eliminated, the target cell, will not be eliminated, giving rise to HLH. So if the cell does not have perforin, it can release all the granules, but it's like shooting with a gun, but your bullets they are blanks. They don't have any ammunition in them. That is what, if you don't have perforin, that was the first genetic defect that I mentioned earlier. But there can be several other problems. And that is, the cell may have the perforin, but it cannot move these granules from inside the cell into the synaptic space here. And so that process requires many different proteins. There's a very complex signaling mechanism that tells the granules to move from inside the cell into the space, the immunologic synapse space, which is shown here in the middle. And I have underlined in red all the proteins that we now know that have been found deficient in children with the HLH. And this is important because majority of these genes, the genetic defects, are autosomal recessive. And so many of these genes were actually identified only because of the cultural practices of consanguineous marriages, where autosomal recessive diseases then come forward, because majority of us carry a single allele or many different mutations, but we are carriers because a single allele does not manifest the disease. But we now know of all of these genes, majority of them are autosomal recessive, and when you have two defective alleles, you manifest the disease. Two of them are actually X-linked, and so only boys will be affected, but many of these can be manifested very shortly after birth or in the first year of life. So this now allows us to expand the pathogenesis. So we know that the cytotoxic lymphocytes will become activated if they cannot kill the target cell. And so the lack of killing of target cell can now be traced all the way back up to either absence of perforin, absence of one of these signaling proteins called SAP. This is on the X chromosome. So the disease is also known as XLP1, X-linked lymphoproliferative disease, but this is the name of the protein or the gene. And then all the genes that contribute to the the cytotoxic granule secretion. If you're missing any of them, you cannot kill the target cell, and if you cannot kill the target cell, those lymphocytes are activated. We now also know that the second X-linked gene that I mentioned, called XIAP, and there's another one that was described recently in the literature called NLRC4. These genes control a new type of organelle in the cell called inflammasome. We all need inflammasome to protect us against viruses and bacteria by just upregulating inflammatory systems in our cell. These genes, XIAP and NLRC4, are components of the inflammasome, and they keep it under control. If you have mutations, either loss of function mutation in XIAP or gain of function activating mutations in NLRC4, the inflammasome is always active. And that leads to large-scale secretion of this cytokine called IL-18, which then does the same thing, activates lymphocytes. So there are many now known genetic disorders that will cause HLH in the baby. And because of these findings, we now have new tools and understanding. We can now identify lymphocyte activation very quickly and reliably using this marker of soluble IL-2 receptor. So this was included as in the 5 out of 8 diagnostic criteria. So if the patient had 6 or 7 criteria met, because all you need is 5, they will be diagnosed with HLH. But if the soluble IL-2 receptor is normal, then it is not HLH, because it means that the lymphocytes are not active. And remember, in HLH, the lymphocytes must be active. Another new marker is this cytokine called CXCL9, which is a marker of interferon gamma activation. And so if you recall, I told you that it is the cytokines such as interferon gamma that are secreted that are important in the pathogenesis. So we can measure, sometimes you can measure interferon gamma, or easier to measure CXCL9. And we now also have flow cytometry-based assays that allow us to measure perforin, the 2 X-linked proteins, and the whole movement of the cytolytic granules. All of this can be measured with flow cytometry very quickly. So here is one example of the flow cytometry analysis of perforin. So on the top is a normal individual, and what we're looking for is the red histogram. So this is the NK cells of a normal individual. The red line indicates the presence of perforin in the NK cells. The bottom row is that of a patient, and if you see, there is no perforin. And this assay takes about 24 hours to run, and you can get an answer that not only does the child have perforin, you've also diagnosed the cause of HLH, the absence of perforin. We have similar assays for SAP and XIAP, which are the two X-linked proteins. And then finally, you can measure the entire lytic granule secretion by this assay, which measures, it's called CD107A. And so this is the lytic granule inside the cell. Normally, this protein called CD107A is only present inside the granule. It is not on the cell surface. But when the granule empties its contents in the synapse, CD107A now is exposed, and you can identify that using a fluorescent labeled antibody in flow cytometry, and that can be detected readily here. So on the top is a normal individual. If you look on the left graph, there is no CD107A on the cell surface. It should be on the right here. But when you stimulate these cells now, CD107A is exposed. On the bottom row is a patient with primary HLH. Again, at rest, there is no CD107A, but even after stimulation, there is barely, almost no CD107A detectable. And this is how we actually diagnosed a homozygous mutation in a gene called STXBP2 in this patient. So the advantages of the flow cytometry assay is that this is a functional assay with CD107A, and you can measure the function of 5 genes simultaneously. So if CD107A is normal, then we know that all these genes, they are normal. They're functioning normally. If it's abnormal, it's one of these 5. So with these flow cytometry assays, we can now rapidly and reliably diagnose primary HLH. You can still do genetic testing, and we still do them, but the problem is that you cannot rely solely on the genetic test. One is because HLH is autosomal recessive. So if you find one mutation, then you are left confused. You don't know, is this the cause of the patient's illness? We don't know all the mutations. So sometimes we find something that is an abnormal sequence, but is that a normal variation or is it a mutation? That is sometimes very difficult to tell. And these results take 4 to 6 weeks. And if you have a sick baby in front of you, you cannot wait 4 to 6 weeks to confirm whether this is primary HLH or not. We also find that, remember I told you, the disease got its name from hemophagocytosis. Turns out that it is not specific to HLH. This can be seen in many, many conditions, sometimes even normal bone marrow. And in many children with primary HLH, this is actually never seen. So we don't use this as a criteria anymore. And if you recall the 8 criteria that were listed, one of them was this thing called an NK cell function assay. First of all, it is a very challenging assay. It is not available in most laboratories. Even in the United States, there are only 2 or 3 labs in the entire country that will do this. One of them is ours. What we've learned is that it's a very non-specific assay. So half the time it gives you an abnormal result, regardless of what the patient's diagnosis is. So we don't use this anymore. And so basically what I'm trying to tell you is that the HLH 2004 criteria may have been appropriate back in 2004, but now that we know more about this, what we are learning is that an elevated ferritin does not matter how high. There are some papers that mention that the ferritin above 10,000 is more specific to HLH. In our experience, that is not true. Even though I mentioned soluble alpha receptor is a requirement to diagnose HLH, it also is not specific. You cannot diagnose HLH without elevated soluble alpha receptor, but just because it is elevated does not guarantee that it is HLH either. And if you all recall, fever, splenomegaly, cytopenias, these are features of many infections, and sepsis sometimes can give rise to that. And of course, leukemias and lymphomas, like I've already mentioned. In the HLH 2004 criteria, also not included are these challenges that If the fibrinogen is normal or elevated, it is almost never HLH. If you have a high white count, usually it is sepsis or leukemia. But the criteria don't mention that if you have a white count, it cannot be HLH. And as I showed you by an example, that lymphadenopathy is almost never seen in HLH. So if there's a lymphadenopathy, usually we're dealing with something else. So I'll give you one other example. Another full-term newborn was diagnosed with HLH, and that's because, again, a male found to be jaundiced at day 14 of life, so a little late for the usual causes of jaundice. And then were found to have hepatomegaly, thrombocytopenia, and leukopenia. All the cultures were drawn and antibiotics were given, but that was negative. And then he was noted to have elevated ferritin and elevated soluble alpha receptor. Initiated HLH therapy, but his condition continued to worsen. And so they transferred this baby to our center, and shortly after arrival, the baby died. And basically what he had was disseminated herpes simplex, which is a treatable condition and can manifest with the same features that we find in HLH. And again, just like this one, we have now identified several infections that were confused as HLH. And so the criteria, the diagnostic features, what they describe is just systemic inflammation, and that can happen if you have a primary defect in the immune system. Even with a simple virus, you can get full-blown inflammation causing HLH. Or if you go in this diagram all the way to the left, you may have a completely normal immune system, but a very inflammatory stimulus, such as lymphoma. These are all the infections that we commonly see that can cause HLH, and I'm sure there are others. HSV I did not put on there, but sometimes that can do that. So histoplasmosis, ehrlichiosis, dengue, all of these can do that. And so it's the same thing, like I mentioned, lymphomas or many infections or some other inflammatory causes. All you need is a release or a large bucket of inflammatory cytokines that has been dumped in the blood. And now you get activation of lymphocytes, which then release more inflammatory cytokines, and then you get activation of macrophages, which then leads to clinical manifestations of HLH. So all roads can lead to HLH, and these are the diseases that we know of that can lead to the manifestation of HLH. In children, adults, in newborns, we've seen all of these conditions. And this is important because the current recommendations are that, if you don't have a genetic defect, then it is secondary HLH. And the current recommendation is that the initial therapy should be the same for all children with HLH, whether it is primary or secondary, and that treatment should not be delayed. But here's the problem. When the treatment is tightly coupled to the diagnosis and the obvious diagnosis has been accepted, the outcome will be catastrophic. And so the treatment for HLH, most people will use etoposide plus dexamethasone. Our French colleagues use ATG plus prednisone. There are many other diseases, treatments described in the literatures. Anakinra, alemtuzumab, these are just some examples. Because if you have familial HLH, when you give them these immune suppressive therapies or chemotherapy, you are putting out the fire. But if you have infection, you're actually fueling the fire, only making things worse, like we saw in the baby with the herpes simplex infection. Same thing if you have a malignancy such as leukemia or lymphoma. When you give such a child dexamethasone and etoposide or any of the other treatments listed, you do get temporary response, but that is actually only a false sense of security. What you're doing is selecting for clones which will actually then give rise to a harder to treat lymphoma or leukemia. And just because the patient responds to immunosuppressive therapy does not mean that they have HLH, because many inflammatory infections such as viruses, mycobacteria, leishmania, and many neoplasms I've already mentioned, they are hyperinflammatory and they will respond to short courses of steroids. But that does not mean that the child has primary HLH or that they don't have an infection. And so I've already mentioned that many leukemias and lymphomas look like HLH. And so just because, and if you don't treat the underlying condition, the HLH will recur. So just because it recurs does not make it primary HLH. So what I've tried to convince you is that the diagnostic criteria that we consider HLH 2004, I would not say they are diagnostic. They should raise the suspicion for HLH, but it is not sufficient to diagnose HLH just based on those criteria. We need more. And so when to think of HLH is anytime you have a child with prolonged fever, inflammation of the liver, reduced fibrinogen, and you've made sure there is no infection, no leukemia or lymphoma. Elevated ferritin and cytopenia should make you think of it, but it's not sufficient to diagnose. If there is a family history of unexplained death in childhood, unexplained liver disease, inflammatory bowel disease in young boys can also be a sign of HLH. And clues that it may not be HLH are elevated white count, normal fibrinogen, normal soluble alpha receptor, if you have that, the presence of positive DAT or Coombs test, lymphadenopathy, and a normal liver enzymes, they should all make you suspect that this is not HLH. So this is our algorithm. I just show it on here because it is freely available on our website. If you just Google HLH Cincinnati, you will find this on our website, and you can download it, use it to, if anybody suspects HLH, whether it is in a baby or in any other child. And so we in Cincinnati, we wait for the test results. We don't jump to the diagnosis based simply on those criteria. Unfortunately, many times this happens on a Friday afternoon or Sunday when we don't have testing available. So we sometimes will start with dexamethasone and wait to add etoposide if we need to. If the genetic testing comes back as negative, then we have to stop therapy and find what is it that we're missing, the malignancy or infection. I will actually skip this last part in the interest of time, and I will end here. Just know that the definitive treatment for primary HLH only is bone marrow transplant. There are newer ways of transplanting children that have become safer and more effective that we continue to explore. And with that, just summarizing that the HLH 2004 criteria are not HLH. All these clinical features just describe systemic inflammation. Always think of malignancy and infection even in a newborn. And if you have anybody ever has a question, feel free to email us. This is the email address, hlh@cchmc.org. We monitor this email every day, and we will be happy to respond and answer any questions and help you out with your diagnosis dilemma. Thank you, and I will be happy to answer questions at the end.